You're in a hospital bed. You're hurting badly. Maybe after surgery, maybe from cancer, maybe from a broken back, or pancreatitis, or sickle cell disease. And you press the call bell because the pain medication isn't working. The nurse walks in, looks at the computer, and says, "You're not due yet." And suddenly, something shifts. You stop feeling like a patient and start feeling like a problem. Welcome to Beyond the Stethoscope. I'm Arne Faklam, a nurse practitioner and fellow of hospital medicine. And this is where we explain what's really happening behind the scenes in healthcare in a way that actually makes sense. Today we're talking about one of the most emotionally charged, frustrating, and misunderstood parts of modern healthcare: pain control in the hospital. And this conversation matters because almost everybody listening either has experienced this personally or loves someone who has. So let's pull the curtain back. Before we jump in, if this is the kind of healthcare information you wish somebody had explained sooner, follow the podcast wherever you listen. And on YouTube, hit like and subscribe. It genuinely helps more people find the show. And if you want practical tools to help navigate a hospitalization, you can download the free Plain Speak Health Hospital Survival Toolkit and the medication guide at ps-health.com. That's ps-health.com. Let's start with something important. Pain is real, and pain is personal. One person's 8 out of 10 may look completely different from another person's. Some people are crying, some people are quiet, some people joke through pain, some people shut down completely. And hospitals know this. But here's the difficult reality. Pain management today exists in the shadow of the opioid epidemic. And that changed everything. Years ago, pain was often treated aggressively. Hospitals were criticized if pain wasn't controlled. Pain became known as the fifth vital sign. But over time, opioid addiction, overdose deaths, pill mills, and inappropriate prescribing forced medicine into a massive correction. And now, the pendulum sometimes swings the other direction, where patients with legitimate pain feel distrusted, undertreated, or dismissed. And honestly, sometimes they are. Not always intentionally, but it happens. Now let's separate a few different kinds of pain because hospitals think about them differently. First, acute pain. This is the easier category. Broken bones, kidney stones, major surgery, trauma, burns. There's a clear event, clear tissue injury, clear reason for severe pain. Most hospital teams are very comfortable treating acute pain. But even here it can become complicated fast, because pain medicine is not risk-free. Too much opioid medication can slow breathing, drop blood pressure, cause confusion, cause falls, cause aspiration, even death, especially in older adults, especially in patients with sleep apnea, especially when combined with alcohol, sleeping pills, or anxiety medications. So while patients sometimes think, "Why won't they just give me more medication?" the hospital team is simultaneously asking, "How do we control pain without accidentally harming this patient?" And that balancing act is harder than most people realize. Next, there is chronic pain. And when someone is hospitalized, yes, there can be acute and chronic pain. This is where things become much more difficult. Patients with chronic back pain, nerve pain, fibromyalgia, failed surgeries, severe arthritis, or chronic opioid use often arrive at the hospital already taking significant pain medication.